everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters most to you, to explore new ideas, and to learn together. My name is Leah Whitehead, and I'm the proud mom of a preemie. I'm also a former journalist, and I'm happy to be your host today from Halifax. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation. It's also very well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or a healthcare professional, I invite you to visit CanadianPreemies.org. That's the CPBF website, and there you will find resources, the latest projects, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so we invite you to bring your voice to the table, leave your comments in the comment section or your questions, and we'll be happy to try to get to those during our program today. And it's also great to hear where you're watching from, so please share where you're viewing today's program from. On to today's topic, we are talking about growth and very preterm infants. Is bigger better? If you've been in NICU, whether you're family or healthcare provider, then you'll know that there tends to be an obsession with weight gain. And it's not unusual to hear families talk about how they're just waiting for their baby to gain a little bit of weight before they can go home. The fixation with weight can come with some unintended consequences, including families missing out on an opportunity to breastfeed because they're just trying to get baby's weight up so they can be discharged. Well, today, that's what we're going to be talking about. We're going to be joined by neonatologist Dr. Marc Beltempo, who will explore how daily weight gain is not the only indicator to evaluate growth in the neonatal intensive care unit, and how sometimes we have to look at the big picture. Dr. Marc Beltempo is a neonatologist and scientist at the Montreal Children's Hospital in Montreal, and he's the associate director of the Canadian Neonatal Network, or CNN. CNN is a group of Canadian researchers who collaborate on research issues related to neonatal care. The network maintains and holds a standardized NICU database since 1995 that is used by a variety of Canadian researchers to improve neonatal care. Dr. Beltempo's research focuses on evaluating how to improve the care of very preterm infants. Using clinical and administrative databases, he is studying the effects of different healthcare delivery models, resource allocation, and interventions on quality of care. And of course, the main objective is to improve quality of care to improve outcomes of babies. Welcome, Marc. We are very happy to have you join us today.
Thank you so much, Leah. It's a pleasure to be here today.
I'm going to pop your presentation up there and I'll let you get right to it.
Perfect. So I'm guessing the slides are working. I'm just going to try back and forth while your sound is on. Everybody's seeing this, I'm guessing?
Yep, looks good.
Amazing. Great. All right. Thank you so much. Again, to everybody in the community, it's just a pleasure to be here on a Friday early afternoon to share and discuss about growth in very preterm babies and is bigger better. So just as disclosures, as Leah mentioned, I do a lot of research, and a lot of that receives funding from the different organizations here, including Canadian Institute of Health Research, the Quebec Institute of Health Research, the Children's Foundation, the Ministry of Health in Quebec, and with the support of Canadian Neonatal Network. Just a bit like Leah mentioned in the introduction, I'm Associate Director of the Canadian Neonatal Network. For those of you who don't know us, we are a collaborative research network that was founded in 1995. And we collect data on all very preterm babies admitted to the 32 NICUs in Canada. The whole point of this infrastructure is to actually collect, monitor, and improve care and experiences of families and babies so that babies can be healthier over time. And that's what we've been doing since 1995. So going towards what we're going to talk about today, what I wanted to focus on today was what is growth? How do we evaluate it? And does timing of growth matter? Referring mainly to the first 2 weeks in the NICU, talking about the post-NICU growth and what affects growth in the NICU. And also, does growth matter in preterm babies? So I wanted to start off a slide with a question for all of us, comparing two persons. Person number one is male. He has 30% body fat. And person number two is also male with 20% body fat. So that's their body composition. So which one would we think is healthier first on? If I look at this and think about an adult male, I'd be thinking, well, probably the one with less fat is a bit healthier. Well, I think the key question is, what is the age of the person we're assessing? An adult male with 20% body fat is at a slight health disadvantage compared to somebody who's a little bit lower in terms of percentages. But what we do have to know is that for babies, they actually have a lot of quote unquote fat tissue, nearly about 30% in term babies. So, and they're healthy at that age. So it's all about timing. So we can't have a single metric to say, well, this type of percentage of fat is okay at this age for everybody or not. It depends on a lot of things. So just going towards growth, weight, and body composition, that helps illustrate that there are important differences in goals and expectation for growth, weight, body composition, and length based on your stage of development, whether you're in the womb, and even then it depends on which trimester, because there are different phases of growth and different types of growth in the uterus. After that, there's the neonatal period. So depending on where you are in that period, we're expecting and we're hoping for different types of growth patterns. Same thing during childhood and adulthood. And of course, we have to keep in mind that there are important differences between sexes and ethnic backgrounds. So going towards the first question, which is, what is growth? If you open up Wikipedia, the definition for growth is essentially refers to physical growth to increase, which is an increase in size. So this can be weight, length, or what we call height, head size. And for those of you who've been through the NICU experience or healthcare providers, that usually refers to the head circumference. So measuring tape around the head, and is that growing or not? And another one can also be changes in body composition over time. Are you gaining lean body mass, or are you gaining more fat tissues as you're gaining weight, for example? And if we've established that growth is a gain in something, whether it's length, head, or weight, what affects growth in the womb and throughout the lifespan? Well, here, if you start on the left, you have the figure of a pregnant person with a baby inside. From there are multiple prenatal factors that will affect the growth of the baby while the baby is in the womb, whether we have undernutrition or malnutrition and due to non-access to food or non-intake. You can have medical conditions, whether it's preeclampsia, type 1 diabetes. You can also have other factors like gestational diabetes, maternal obesity also affects the growth pattern in babies, type 2 diabetes, and also even the type of nutrition during pregnancy. That's going to affect the placenta. The placenta is the nutrition going to the baby. And then there are different placental factors which can affect how the nutrients are brought from the placenta and the mom to the baby. And then that's going to lead to the baby being either large, small for what's expected, or at expected quote unquote age. And all of that can also affect your long-term growth patterns and your long-term health outcomes, like whether it's cardiovascular disease, blood pressure, diabetes, etc. But one thing that's in this slide, and if we just focus on, is at birth, you hear all these words, whether it's SGA, AGA, LGA, and what does that all mean when we talk about that at the bedside? So these are maybe 4 terms that I just want to go over, like SGA for small for gestational age, AGA for appropriate, quote unquote, for gestational age, LGA, which refers to large for gestational age, and then the other word, which is IUGR or intrauterine growth restriction. So what does all this mean? And if your baby was SGA, LGA, how does that apply, or what does that mean? So before we go into those definitions or starting points of weight characteristics for neonates, let's take a step back and go to what's a growth percentile and what's a growth curve, because these are tools that are used to evaluate growth in every metric almost on a daily basis or on a weekly basis in most units. for those of you less familiar, a growth percentile is essentially a percentage, so ranging from 0 to 100, and measures how your child compares to other children for the same sex and age. So what that means is, does being at the 15th percentile mean your child is part of the worst 15%? No, because when you create these growth curves, you need to have a kid or a person that's at the top 100% of the size and another one that's the 1% smallest. But that does not correlate with brain happiness, long-term outcomes, especially if that's quote unquote your growth potential or your genetic potential for size. You have people who are just genetically smaller, others who are genetically much taller. That happens. So again, these numbers are just there to help us say, well, where's the starting point and where's my child at this point? So like I mentioned, being at the 90th percentile does not necessarily mean that your kid is 90% better than everybody else. That's not how it should be interpreted. And this is just an example of what these growth charts look like. So if they exist for weight, length, head, body mass index, and again, they vary based on sex, ethnicity, and gestation. So there are a few of them out there in terms of types of growth curves that are used by health professionals. Most of us use certain one or two that are generally recommended. But just to give you an idea, if you look here on the x-axis, it's the age in postnatal weeks. So let's say in gestational age, I mean. So let's say here at 40 is a baby that's born at 40 weeks gestation. And then all above on the red line, you have curves. One at the bottom is for weight. The set of curves above is for head circumference. And after that, for length. And then when you generate these curves, like I mentioned, you have to have a baby that's eventually going to be born at the first percentile. You're going to have another one that's at the 50th and another one that's at the 100th. That's normal distribution of variations of people. So you just have to be mindful when you understand or interpret this. So going to SGA, LGA, and AGA, essentially small for gestational age is just a metric that says below the 10th percentile. But that means you have 10% of kids that are by definition SGA. And same thing for LGA, which is large for gestational age or larger than expected, but that essentially is another 10% of kids. And the AGA group is babies between the 10th and the 90th percentile. So like I mentioned, SGA and LGA may not always be bad when you hear those terms. You just have to be mindful that this is where we're starting from. Yes, it's associated with certain things like early neonatal challenges like glucose control, but that helps the medical team make decisions on types of monitoring to do in the short term, but it also has to be considered what's going to affect the growth long term. And the last term we talked about was intrauterine growth restriction. That's something different from the AGA, LGA, and AGA terms, where it generally refers to a fetus or a baby that in utero did not achieve their potential growth potential. So for some reason, the baby was growing well, and then something happened where the baby was not able to grow. So again, you have to be mindful of what's explaining this. And going to the growth curves, and when we talked about all these percentiles of where a baby starts, well, the reason why it's important is you generally want to follow your growth potential and follow your percentile after birth or near it. And again, it depends if you're, for example, born too large because you were exposed to growth factors that made you larger than what you were expected or supposed to be. But this is an example where, for example, a baby was born, if you take at the length at the top near the 50th percentile and then ended up at the 10th percentile, probably during the NICU phase, a few factors affected it. And then after that, the baby stayed growing well at the 10th percentile. This can be normal. But again, you have to understand where the baby started, what's the genetic potential, and what's the growth pattern, because you can even see the weight is also following well a little bit above the 10th percentile. So again, this all has to be put together and individualized for babies. And what that looks like in the NICU generally in terms of weight gain, generally we look at about 18 grams per day. Length, they're gaining about 1 centimeter per week, and head about 0.5 centimeters per week. But again, what's your baby's growth target or potential? That's affected by so many things. One of them is where you start. So are you LGA or small for gestational age, or did you have something that restricted your growth and then you have to catch up while you're in the NICU? Other things include like your health status. If the baby is very sick from his or her lungs, that's going to affect the capacity to grow in that period of time. There are medications that affect the weight and length gain. Gestational age at birth is another factor. And also, like I mentioned, it depends which growth curves you use as reference. So if you're using one and then you change every time you measure the baby, that's not helpful. And here's an example of a baby boy. You can see, let's say the bottom curve at the bottom right, which is the weight. The baby was by definition large for gestational age at the 90th percentile in the context of gestational diabetes, which actually accelerates growth sometimes. But that's beyond his genetic potential in that situation. But then as you can see, after birth, he quote unquote leaned out, where he decreased in growth percentile and ended up being closer to the 10th, which is in this case appropriate. So we just have to be mindful of what's the starting point and where are we going and why are we going there. And which brings me to saying that weight gain is not everything. As a neonatologist, we love to measure, to follow, to quantify, and control as much as we can. But weight gain is not everything, and it's not the only indicator of growth. So just to give you an idea, when we say 18 grams per day, that may not be realistic for certain babies, depending on the period of where they are in their NICU stay. Just to keep in mind that if the baby is born at 500 grams, gaining 18 to 20 grams per day is 4% weight gain per day. That is huge. For an adult, it's almost like a 100-pound adult. It would be almost gaining 4 pounds every day. That's not necessarily realistic in their early NICU course. And another factor that those of you who've been in the NICU have seen is that growth is not linear. You don't gain exactly 18 grams every day. You have to take a step back and see, well, over 4 or 5 days, what happens. Sometimes a baby will gain 50 grams and another will lose 10 grams. And the day after, another will gain another 60. It's about understanding and seeing that pattern and not necessarily making changes on every small thing, depending on what's happening with the baby. And the last thing is you want to stay proportionate. You don't only want a baby to gain weight. You have to make sure that they're gaining length and head. And lastly, weight loss can sometimes be good, which will bring me to the next subject. So if we focus a little bit more the message on the very preterms, the ones that are generally born less than 32 weeks, and if we talk a bit more about the extreme preterm babies, less than 28, 29 weeks, generally weight loss in the first 2 weeks is actually good. I see so many providers or even families saying in the first few days after life, oh, they're still losing weight. Yeah, that's actually a good thing in general, because the first 2 weeks after birth, there's a lot of water shifts in babies. And generally, most of the weight loss they are having is water that they had accumulated from before birth because they were in the placenta, in the uterus. So that when the baby comes out, they are expected to lose a certain amount of water. And that's actually associated with a little bit better outcomes. And usually it takes them at least 7 to 14 days to regain their birth weight, just to be mindful of that. So here is on the x-axis, one of my students who did a study on looking at babies who survived without having chronic lung disease of prematurity compared to those who either died or had some kind of lung disease. So what you see here is you start off at day 1 on the x-axis. You have each age after birth. And then this is in percentages. So let's say at birth, you're born at 0% weight change. The babies who did not have BPD or lung disease are the ones in red. So you notice they, in percentage, actually lost more weight and takes them more time to regain birth weight. So that, in this specific context, can actually be okay. So we just have to be mindful of that. And again, clinicians have to adjust the weight because losing too much weight is not necessarily good, but we just have to be mindful in our expectations. And after that, like I mentioned, though, the first 2 weeks, we talked about a lot water. Weight loss is good, but there's still a nutritional emergency for neonates. There's a high need of babies as soon as they're out of the uterus, especially for extreme preterms, to have appropriate caloric intake and protein and sugar and fat to avoid them actually losing good lean body mass. So that's why a lot of people will talk about a nutritional emergency in the first hours after birth, where we have to start nutrition through parenteral nutrition, or what's called TPN. And starting appropriate early nutrition is associated with better brain growth, and better lung health. But we won't see that growth in the first 2 weeks, like I mentioned, but it's important to avoid losing that good lean body mass that you want the baby to try and build upon. And in the NICU, what's going to affect the growth? Well, we talked about starting early appropriate nutrition. That includes caloric intake to balance out the energy expenditure, what's called macronutrient intake for those of you who are into proteins, sugar, and fat. And then after that, you have the different types of intake. Babies who are on intravenous intake versus feeding, the composition's a bit different and the needs can be different. So a baby that may need a little less calories to grow with an IV, but a little more to grow with if you're feeding them, but that's also expected and okay. And even amongst the type of feeds, whether it's an oral feed, breastfeeding, bottle feeding, gavage, continuous feeds, all that also affects the capacity to extract calories. The type of milk also affects the amount of calories and the way they grow. There's medications, how sick the baby is, genetics, etc. And just to emphasize the comment about growth and breastfeeding, as a medical principle, anything given in the digestive tract, which is either by mouth or by gavage or by breast, is better than intravenous. And the earlier we start as clinicians and as families to expose the baby to milk, and whether it's mother's own milk if we have access to it and mother is producing early on, or we use donor breast milk to bridge, or even formula in those cases, is going to be better than just using IV nutrition. And just keeping in mind that mother's own milk is the best nutrient we have, and there are tons of other immune microbiome effects. But from a nutrition point of view, we do have to keep in mind that there are a few things that need to be added to meet the nutritional requirements of very preterm babies. And for those of you who've seen the NICU course, we add these powders to the milk, and these are essential because they contain additional calcium phosphate for bone health. Sometimes we'll add some protein to increase the protein content of the milk to be able to maximize growth and lean body mass gain. And also there's some ways to fortify the milk to add additional calories that the baby needs. And just going to my initial comment of not all human milk is the same, there are two things in this slide that I think are just relevant for us clinicians to know about and as families, is that first, whether we have donor human milk versus mother's own milk, there are differences in those. Mothers who are giving milk to a milk bank are usually mothers that have been lactating for at least 3-6 months or even later sometimes, depending on the milk bank policies. And that type of milk has different calories, different constitution, different proteins also. And this is what we see in this slide. In this table, you'll have, for example, on the first column, what's called donor breast milk compared to MOM, which is mother's own milk. So just the caloric content for 100 mLs, donor breast milk on average had 60 versus 65 calories in mother's own milk, just as a proportion. So just baseline, you see there are differences. And then secondly, what's relevant also is if you look at the mother's own milk group, between different mothers, and this was 67 lactating mothers, they had a variation of some were producing milk that had 42 calories per 100 cc's, and others were producing milk that had 127 calories for 100 mLs. So you see there's huge variation, and we see the same things with donor breast milk. So it is possible that some women are producing higher caloric content milk versus less caloric content. That's still okay. But it just means that maybe in one situation, we need to add more fortifier to make sure that the baby has enough calories to grow and to supplement in caloric intake that amount of milk. And why are we focusing on these different growth parameters? Well, maybe just to synthesize, growth is important for short and long term. It's associated with brain development, especially head growth, and that can affect long-term development and long-term potential also. But we do want to be mindful, like I've mentioned, that we have to follow and that there are babies that despite appropriate calories, if they're so sick, they may not be able to meet what we want them to meet in terms of growth potential. But there is an opportunity for catch up, whether it's in the NICU, but a little bit later when they're a little bit healthier, or even after when they go home. And what this refers to is called catch-up growth that we'll often see depending on when the baby is. So here, for example, on the x-axis, you have the age, and on the y-axis, you have the weight of the baby. And you see this bolded black line. If you start from the left, you see the baby in the first maybe weeks or months after birth was kind of doing okay. Something happened, maybe during the NICU, got sicker. And then eventually, though, starting picking back up to where they were initially at, closer to the third to fifth percentile. And this, we see that often also. And we just have to be mindful on where is the baby in his or her trajectory. And for those of you who do follow up, or for the families out there that are watching this, it's just important to remind the clinicians who should know this in general, is that growth curves for neonates, especially after the NICU, need to be adjusted for how premature baby was. So if the baby was born 6 weeks premature, we don't plot or compare that baby to a 1 month old based on after birth. You have to go back in time. So for example, in this slide, you see on the x-axis, for example, at I think it's 36 months. No, sorry. This is maybe 8 months. You have to back up by 6 weeks to compare the baby. And then that's how you're supposed to plot the growth curve for after the NICU stay usually. And all that to say today that if you retain one thing, is that weight gain is not the only metric, and growth has to be individualized, and our goals and our expectations have to be. And that's why approach to nutrition in the NICU and after is a multidisciplinary process where we have to identify goals, monitor them, adjust intake, and adjust our goals based on the responses of the babies. And there's a great paper looking at optimizing growth of very preterms and kind of synthesizing this multidisciplinary approach. So in conclusion, growth does matter and nutrition does matter, but weight gain is not the only metric. So if we're just looking at these daily metrics, we just have to look at the overall trend and take a step back sometimes. It is a multidisciplinary process with the families, the nutritionists, sometimes the pharmacists, and the team, the nurses and the doctors. And breast milk remains the best form of intake for preterms, but sometimes we do have to add a little bit of powder to help improve the caloric density and add some extra nutrients. I just want to say thank you so much for having me today, and I'll be happy to answer any questions.
Thank you so much for your presentation. I have some questions. I don't know how coherent they are. I was scribbling notes as you were talking, but wanted to start with talking about that balance of the focus, I guess, on weight gain, and how do we balance it? Because as you highlighted, it's important. It's not something that we can just take off the table. It's babies need it, especially those very preterm. But how do we keep everybody, not just families, but everybody on the team, to not become fixated on that number and for that to be the primary thing? Do you have any advice?
I think there, again, for me and at the bedside, it's about timing of that number. And why are you emphasizing on it? So it's about the providers, the healthcare providers, to educate ourselves. Why are we monitoring this? Especially in the first 2 weeks, people talk about weight gain. I think we're doing more and more work to talk about, well, it's about fluids. So we're talking about weight, but we're not talking about lean gain, lean body mass. We're talking about it from a medical management point of view. And then after that, there's the medical management for acute issues, because sometimes the baby gets very sick and gains 200 grams because had a surgery. So that's important for us to know. But the reason we're focusing on that is mainly for the water and for the post-surgical care, not for nutrition. And then talking about nutrition with another aspect, saying, okay, what are the nutritional goals? So it's about separating the why we're talking about things. But I think you're right. The challenge is, and I see it all the time, parents arrive, how's my baby doing? What was the weight gain? And that's fine. People want to focus on things, and I think it's natural. I mean, when you eat with family, you want your kids to eat. Like, you think it's healthy for them to eat. So it's always challenging to try and take a step back and say, well, it is important, but it's not, if he or she didn't gain weight, it doesn't mean he or she is not healthy. I think that's what's important.
As someone who has seen lots of babies go through NICU, and then I don't know how involved you are with follow-up, but do you find you can predict how babies will do with their percentiles and weights and that kind of thing after NICU? Is there that catch up where you see like a complete change, or can you kind of predict that as a neonatologist?
The good thing about life is we can't predict very well. So anytime neonatologists try to predict, we're not that good. So I like to take a step back and remind myself that we're not very good at predicting things. That being said, in pediatrics, there are certain concepts, though. The genetic programming of the potential of the first 2 years growth is usually things that happen in the uterus, and there's a lot of paternal factors that determine that growth in the first 2 years. But then after the first 2 years, there's kind of this, especially for length, where the genetic potential takes a bit more space. And that's why you'll see, for example, two tall parents can have a relatively small 1-year-old. But after 2, generally, that genetic potential is going to start kicking in. And then you'll see, well, okay, they're going to be a 6 feet teenager. So that's why, again, predicting is not super easy. And there's a lot of margins of errors.
We do have a question here from Sarah, who's watching. I don't know if the whole thing is showing up there, so I'll read it. For babies that may not need an IV, for example, a 34-weeker, doctors will start with 60 to 80 kilogram per day. So it leads to formula right away, as the mom does not have that kind of volume. We do not have access to donor milk. Is this appropriate to start with this kind of TFI in the first 2 to 3 days?
So for those of you who are not healthcare providers, what she's asking is that for most babies who are born 34 weeks, the goal is actually to avoid IVs. I always tell families and providers and nurses and people or trainees, if you have a choice in life, mother's own milk is way up there. And the worst thing you can have in life is IV. I mean, it's not terrible, but I mean, if you have a choice, that's where it is. And then in between, you have donor milk and then formula. But again, keeping in mind that formula is way better than an IV. I mean, whether it's for attachment, whether it's just for gut priming. So we have this stigma around formula saying that it's bad. And again, putting caveats around that. It's not bad per se. We've used it for years in mothers that don't have enough milk, even in preterms. It's not ideal. In a 34-weeker, donor breast milk is not accessible in most places in the country. And even if you think about level 2 units, most of them don't have donor milk for this type of baby, which is acceptable and okay. So starting the baby on a high fluids to make sure that the baby doesn't have low blood sugars, but only giving formula, whether it's through a gavage tube or by formula, is a common practice, which is associated actually with shorter length of stay. And if the mom starts lactating early on, and make sure you promote, I wouldn't say aggressive breastfeeding, but very proactive breastfeeding in these situations, I think there's a way to get that baby breastfeeding and home breastfeeding on an appropriate weight faster. And that's what a lot of studies have shown when you start at least enteral intake instead of IVs in these situations.
Sarah had another question here as well. Do you have any guidelines on how length of fortification post-discharge? There's a lot of variation. I wouldn't say a lot, but there is some variation on how to tailor that. And you have to individualize it based on the baby. Maybe putting boxes of types of patients. The first one would be, let's say, a healthy preterm baby that didn't have any intestinal complications or growth complications or bone complications. So often the fortification can be tailored based on the weight gain in those situations. But you do have other babies that, whether they had bone density challenges, so you have to maintain higher phosphate and calcium intake in the first few months after, because you want to make sure they get healthy bones. So that's why I'd say it depends on the fortification and it depends on the weight and length pattern. Because you do have some babies that for some reason, after NICU or even during the NICU, they just keep on gaining weight, but they gain weight faster than they grow. So at one point you have to take a step back on the amount of calories you're giving. So those are the two things. I was going to ask about fortification as well, just in that you were talking about how not all breast milk is the same. There's different calories, there's different protein, et cetera, that goes into it. And you mentioned that then you have to tailor the amount of fortification. So I'm just wondering, do you test all the breast milk to get this info, or is it just looking at how baby's growth is doing? How do you come up with those numbers?
Yeah. That's unfortunately, most units, I think some do, and I know some places in the States have started doing that, where they actually test the mother's own milk for the caloric density, and they even do it on the donor milk. That's not accessible or realistic in a lot of contexts. That's why the way it's tailored at the bedside is that you start with usually the first step, because you usually do have to have some kind of calcium and extra phosphate. That's not really an option because there's not enough in the mother's own milk. So you have to give some kind of fortification, and that comes along with extra calories. Now, the question is, do you use what's called 81 calories per 100 cc's, 91 or 100 calories per 100 cc fortifier? Then that's going to be based on the response of the growth of the baby. And more now, especially people who are using donor milk, we're adding protein. It's called liquid protein. It's extra protein you add to the milk earlier, because we know now that, especially with all the analysis that was done on donor milk, there's less protein density. So we do need to add a little bit more too.
It's always maybe just a personal thing, but when people talk about breast milk being the very best and, that's what babies need. And then it's always like, yet we need to add this stuff, especially with the very preterm.
Yeah.
And so is it something that's been explored, or is it worth exploring, of simply giving the baby breast milk or mother's own milk, as you've been calling it, and then adding it like we do vitamin D and iron, like as an add-on? Why does it have to be actually added to the milk?
I think that's a great question. The big one is mainly the calories. Adding the calories, there's no other way of efficiently delivering more calories because it's through the food. So option one would be giving just IV extra calories, which I think we've mentioned. Milk IV is there. So we need to find a way to do that. One option would be to give high calorie feeds intermittently combined with breast milk. But if you're already giving breast milk by gavage, probably the most efficient and consistent way of doing it is adding some kind of powder. And I really do appreciate this mixed message we keep giving families about, well, breast milk is good. We're investing, hopefully, a lot of resources into supporting mothers who are lactating. But then we're saying, well, we need to add this. We need to add this. That's kind of the best way to deliver the additional calories or additional nutrients the babies need. I think that's how I'd summarize that. But keeping in mind that the primary nutrient, the biggest thing doing the work is the mom's milk. So we are adding things, but the base is there.
Besides nutrients and calories and all that stuff, what can families do to help promote healthy weight gain with their babies in NICU?
Yeah. So I split this into two themes. One more the mothers is to make sure that they have access to hydration to be able to lactate, essentially. So this is all the lactation support and all the work that's been done by more people than me, but make sure that she's getting enough calories and a balanced diet. And to their partner, their job is to make sure that they make that food and bring it to her. So I always tell the dads or the other partner saying, well, you're not lactating, but your job is to make sure that your partner who is lactating has access to that food. So it's a team effort in that aspect. The other aspect that we can help promote, like I mentioned, is just making sure that you're able to do skin to skin, because that does increase lactation, being able to stay engaged. And we're talking about family integrated care before this. These are important things that actually help milk production, help attachment, and help growth. So that's important things also.
Is the skin to skin element that it helps promote lactation only, or is there something tied into that and weight gain that goes beyond the caloric intake?
There are probably a few others. We can go into kangaroo care another day, but another benefit that we see with kangaroo care is what's called physiologic stability. So just the temperature control, because you're with somebody else's body temperature. So the mother or the father who's holding is keeping the baby's temperature for them or helping them. So there's a little bit less of that caloric expenditure sometimes that can help. So these are all these small things that are hard to quantify. But what we did see is that in the family integrated care models, the weight gain is actually good.
We have one last question here from Sarah, and we'll end with this. We know powder formula can be a risk, and so I struggle. How can we justify promoting powder formula to fortify post-discharge, for example, adding it to breast milk?
Yeah, I think, again, it goes around, it speaks to what's the goal of doing it. If the baby, for example, there's some babies that just can't breastfeed, or if they're bottle feeding more, they're able to take 60 ml or 2 ounces every feed or 3 ounces every feed, but you can't ask them to do more. So between having a higher dense or higher caloric intake or forcing more intake, and then your options become gavage, sometimes you're better off making sure that the baby only has a good experience by the mouth, and then fortify there, versus trying to force the baby and put pressure and stress on the family who are like, okay, no, we need to make it to 90 mLs and force my baby to feed, which ends up being a stressful experience for everybody.
Mm-hmm.
And the second thing is, again, talking about phosphate and magnesium, you just have to make sure that that's nuanced also, because again, some babies that may have had some bone disease, you want to avoid those babies having long-term bone complications also.
I sat in on rounds with one of our neos, and it was so interesting to have the conversation about feeding tolerance, and how that's often a term we use in NICU. And he just said during the rounds, he said, why do we call it feeding tolerance? It should be feeding enjoyment. And you just underline that. I mean, so important, even when they're that age, that it be associated with a positive experience.
Yeah.
And we just have a comment here from Maria that I want to share because it's just beautiful. Listening from Hamilton, Ontario. My son was born at 24 and 6 and had a 117-day NICU stay at McMaster Hospital. Wow. My son is now 3 months corrected. He's doing so well. We're very fortunate for all of the wonderful care and support from the NICU team. And Maria, you were part of that team. And so many of us who are NICU parents are so grateful for how our babies thrive in and after NICU because of the team. So Marc, thank you for bringing this today, the lens of the interdisciplinary team, of how important it is that everyone work together and that everyone be on the same page. And I just think, these kind of talks of individualizing care are really important to have. So thank you for sharing this with us today.
And thank you for having me. And thank you for the nice comment from Maria. It's very appreciated to hear these stories.
All right. Well, I will let you go to enjoy your Thanksgiving weekend. And thank you for joining us. I'm sure we will see you again soon.
Thank you. It's been a pleasure. Thank you so much.
And thank you, everyone, for joining us online today for this edition of Preemie Chats. A special thank you to our sponsor, AstraZeneca, for their ongoing support of the Preemie Chats program. And just a reminder that if you missed a part of today's session, or if you would like to rewatch it, then you can do that at canadianpreemies.org. And there you'll also find all past editions of Preemie Chats available. You'll find many resources and support options available, and you'll be reminded that CPBF is a charitable organization, and it depends on support to continue its important work. So consider how you can support CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. October is Pregnancy and Infant Loss Awareness Month. So we ask that you join us here next Friday at 1 p.m. Eastern Time for our topic, Love, Loss, and Beacons of Light, supporting yourself and others through grief. You won't want to miss it. I hope everyone has a great Thanksgiving weekend, and thanks again for joining.